Alrighty, I'm going to go ahead and get us started. My name is Melanie Farkas. I'm with the Ohio chapter, American Academy of Pediatrics. We are very pleased to host this webinar about the DTaP vaccine called DTaP Drop-Off, Why the Fourth Dose is a Problem in Ohio, and What You Can Do to Raise Your Rates. So with that, I will go ahead and hand the webinar over to Dr. Rebecca Brady. Dr. Brady is an associate professor of pediatrics at the University of Cincinnati Department of Pediatrics. She's also in the Division of Infectious Diseases at Cincinnati Children's Hospital Medical Center and serves as the medical director for the Ohio chapter American Academy of Pediatrics Immunization Program. So we're very happy to have you here with us today, Dr. Brady, and go ahead when you're ready.
Okay, so thank you for joining, and just the first slide is that I have no relevant financial relationships to disclose. So what we're going to do is it's going to kind of be divided in sections, and after we kind of go through a section, there will be a time for questions. So if you want to type your questions in the chat box, or if there are a lot of questions, we can unmute the line and answer them. So the goal is to increase awareness of pertussis disease among healthcare providers and to promote timely receipt of the fourth dose of the DTaP vaccine in particular, making sure that children receive it before 24 months of age. So there's 5 objectives. First is to review the epidemiology of Bordetella pertussis, the bacteria that causes the disease pertussis. 2 is to discuss signs, symptoms, diagnosis, treatment, and prevention of pertussis. 3 is to discuss DTaP vaccines, including their safety and effectiveness. 4 is to examine the fourth dose DTaP vaccination rates among 24-month-old children in Ohio and also the United States. And finally, to address barriers and formulate strategies to increase timely receipt of the DTaP vaccine doses. So first we're going to talk about pertussis disease and then look at some vaccination rates. So pertussis can go by many different names in many different countries. So the Scottish term is the kink, meaning like a fit or a paroxysm. In Old English, it's gasping cough. Italian is barking cough. French, crow's cough. German, gasping cough. Spanish, savage cough. And Chinese is 100-day cough. And in the U.S., we usually refer to it as whooping cough. So this bacteria requires special media. So this is a blood agar plate, and this is the specialized media that needs to be used. So one is called Regan-Low, which contains charcoal. The other types of agar include Stainer Schulte and Bordeaux Genou. And basically it's described as small colonies that are glistening that look like droplets of mercury. So the bacteria does have some major antigens and virulence factors, including the pertussis toxin, which is extracellular, filamentous agglutinin, which is on the cell surface, a fiambrial agglutinogen is also on the cell surface, and pertactin is on the cell outer membrane. So pertussis is spread by aerosolized droplets. Cases can occur all year, but this is the peak usually from about July through October. It's highly contagious. It's one of the vaccine-preventable infections in the United States that's showing an increasing number of cases. And even if you have natural infection, immunity wanes. So even if you have natural pertussis disease, you can still get pertussis disease again. And immunity wanes about 3 to 5 years after vaccination. So this is a little bit about the epidemiology, and what this photo depicts is John Snow, who's considered to be the father of epidemiology. This is in London in 1853, the Broad Street pump, which the water there was contaminated and led to cholera outbreaks. And the other thing around with a lot of people going to draw water and congregating there was probably also associated with other epidemics, things that could be transmitted from person to person via the respiratory route. So this is the National Notifiable Diseases Surveillance System looking at reported pertussis cases in the United States from 1922 to 2015. So you see there's kind of a lot there in the 1920s, 1930s, 1940s. Then in the 1950s was the DTaP, which had the whole cell pertussis vaccine, and there was a dramatic decrease, which actually stayed pretty well decreased. This vaccine, though, with the whole cell pertussis component, did have more reactions in young infants. And so that's why in the 1990s we moved to the DTaP, which had the acellular pertussis component. And then if you look as we go along, in the mid-2000s, around 2005 or so, we're starting to see an increase in pertussis cases. And that was when the adolescent or TDAP vaccine was introduced. And then 2014, 2013 were a pretty high year, and then in 2015 it looked like it was decreasing again. And then the data for 2016 is still being compiled. So the next slide looks at the pertussis incidence by age group, also over the same time period from 1990 to 2015. So the highest incidence there is still in those under 1 year of age, but you can see that there's a significant amount of variability there. And then the second highest age group is that 7 to 10 years of age, and we especially saw that in around 2014, 2015. This looks at changes in pertussis reporting by state from 2013 to 2014. So some states had an increase, some states had a decrease. Ohio was one of those states where an increase was. Some of the other neighboring states, it was more of a decrease. So it kind of varies again by year to year. So this is the latest report that's been compiled. This is the 2015 pertussis surveillance report. There were 20,762 reported cases of pertussis in the United States, with 6 total deaths, 3 of those under 1 year of age, and Ohio had 827 reported cases. This is an article by Dr. Cherry on the epidemiology of pertussis. This was published back in 2005 in Pediatrics, and basically saying that there's probably between 800,000 and 3.3 million cases per year of pertussis in the United States. So there's even more than diagnosed, because those reported cases on those previous slides actually had culture confirmation, but there may be other individuals who have a prolonged cough that have pertussis, but they may never get the official diagnosis. So this is, again, looking at this estimated pertussis disease burden, so an estimate of over 1 million cases. And this is looking at 2004. There were about 25,827 reported cases, and of those, about 9,800, or 38%, were in adolescents. So this was the reason for adding that adolescent TDAP pertussis vaccine to the schedule. This is another way of looking at reports of pertussis in the United States, going from 1990 up to 2004, again, dividing it by the age groups. So if you look comparing like 2004 back to 1990, where you've seen that big increase has been the 10 to 19-year-olds with an 18.8-fold increase, and also the adults as well with about a 15.5-fold increase. We used to think that infant pertussis was acquired by contact with the mother. This is a newer study published in Pediatrics in 2015, looking at some of the more recent cases. And actually now the most common source for infant pertussis is probably an older sibling. Mothers are next, but what we've introduced is now we've introduced that mothers are supposed to receive the DTaP vaccine during each pregnancy, preferably between 27 and 36 weeks. So that does seem to be associated with a decrease in mothers acquiring pertussis and then also transmitting pertussis to their infants. So why have we seen cases of pertussis increase? There have been some changes in the organism, but there really isn't evidence to say that that's the cause of this increase in incidence of pertussis. There is increased awareness, increased recognition, incomplete vaccination, but probably the biggest factor there is waning immunity, especially in adolescents and older adults. So this looks at pertussis and the estimated duration of immunity. So natural infection from a study back in 1995 was estimated to have immune protection for about 15 years. These are various studies back in the 1990s with the whole cell vaccine, probably about 6 years or so. Some of the earlier studies with the acellular vaccine suggested about 6 years. As you'll see later, some of the later studies suggest this may not be quite as long. So this is just another diagram with the pertussis bacteria, and you'll see it attaching to the cilia. Those are on respiratory epithelial cells. So what is known about the pathogenesis of pertussis is that it's non-invasive. It just kind of attaches. It does release toxins, so it's toxin-mediated disease, and it doesn't spread beyond the respiratory tract. There's a lot we don't know about pertussis and the bacteria that causes pertussis. We don't know all the virulence factors that are essential for pathogenicity. We don't know exactly what the serologic correlate of immunity is, what antibody titer to which antigen is really what you need for good protection. And we don't understand all the mechanisms by which vaccines provide protection. So a little bit about pertussis, the illness. There's an incubation period of about 7 to 10 days with a range of 4 to 21 days. And then we often describe it as being in 3 different stages. So the catarrhal stage is the first stage. It lasts about 1 to 2 weeks. And this is when you really just think you have the common cold. So most people aren't seeking medical care necessarily during this period. They're not getting diagnostic testing. And so we often don't diagnose pertussis until we're in that second stage, which is that paroxysmal stage. Lasts about 4 to 6 weeks. This has the coughing spasms, vomiting, the post-tussive emesis, syncope, cyanosis, and then that characteristic whoop after the coughing spasm. For infants under 1 year of age, pertussis can manifest as apnea without that characteristic whoop, and the morbidity and mortality is highest among those under 6 months of age. And then the final stage is the convalescent stage, lasting about 1 to 2 weeks on the average. They have a gradual recovery over weeks to months, and 50% of adolescents cough for more than 9 weeks. So I think you can see this is why the Chinese refer to pertussis as the 100-day cough. So this looks at some of the complications of pertussis in infants and young children in the United States, looking at 1997 to 2000. So especially in those under 6 months of age, there were 7,200 cases with about 4,500 hospitalizations, so over half were hospitalized. 847 had pneumonia, 103 had seizures, and there were 56 deaths. In the 6 to 11-month-olds, there were 301 hospitalizations among about 1,000 children, so again, about a third were hospitalized. 92 cases of pneumonia, 7 had seizures, and 1 death. And then as you get on out, the 1 to 4-year-olds, about 3,000 cases, 324 hospitalizations, 168 cases of pneumonia, 36 seizures, and again, 1 death. So this looks at reported pertussis cases by age in that 2015 pertussis surveillance report. So there's a big group there of 11 to 19-year-olds, about 32%. And then there's about 22% in adults. And then there's a lot even in like 1 to 6 years of age where you think would be vaccinating. There's still 18% there. So these are just some photos of pertussis. This is a child that has some broken blood vessels, that redness in the eye, and those facial bruising underneath the eye. So this is just how very severe the cough is. And then the other panel, it's really difficult for this child to stop coughing and get air. So with making the diagnosis of pertussis, the older test we use, or you can still use, is the nasopharyngeal aspirate, and this is just showing really sort of trying to get in there, getting in that really back part to the nasopharynx. So pertussis, you can make the clinical diagnosis with usually that's that prolonged cough with then the whoop sort of sound at the end of the cough and the post-test emesis often. Some of the laboratory features, the CBC may show an elevated white blood cell count with lymphocyte predominance. Cultures, the older test, probably a lot of labs have gone away from it because it's somewhat labor-intensive. It requires the special media. It's best if it's done less than 3 weeks after symptom onset. So you can do a nasopharyngeal aspirate or a saline wash. A lot now are just moving to using a nasopharyngeal swab, but it needs to be a dacron or a calcium alginate swab. And then you really should get that specimen quickly into carrier media or directly inoculate onto a plate. So what a lot of labs have moved to now is the polymerase chain reaction that you also can do on the nasal swab. Serology is not generally available. It's usually a send-out laboratory, and it's somewhat of a retrospective diagnosis because you're looking about 2 to 3 weeks or 2 to 4 weeks later for that twofold increase in pertussis toxin or antibody, or a twofold increase to antibodies to 2 other pertussis antigens. So this is just another slide looking at the diagnosing testing for pertussis and the optimal timing. So the culture is kind of in that first 2 weeks after cough onset. A lot of them are not even hardly presenting for care during that period, so that's why we've moved on to the PCR because it's still useful out to about 4 weeks or so. And then the serology anytime after about 2 weeks after cough onset on out to about 12 weeks. These are just some of the other differential diagnoses to consider when you're thinking about pertussis. So there's another related bacteria called Bordetella parapertussis that can cause a very similar illness. Some of the respiratory viruses, in particular adenovirus and RSV, cause a similar clinical picture. The walking pneumonias like Mycoplasma pneumoniae and Chlamydia pneumoniae, and then Chlamydia trachomatis can be a cause of an afebrile pneumonitis in young infants. Especially with toddlers who are putting a lot of things in their mouth, you have to think about foreign body. Cystic fibrosis, you're probably going to get a much longer history. The child may be losing weight. The child may have some diarrhea, malabsorption sort of symptoms. And then asthma is usually the wheezing, and again, there may be a history of similar prior episodes. Okay, so the next we're going to focus more on the infant DTaP vaccine and its safety and effectiveness. So this is the 2017 United States Recommended Immunization Schedule for Children and Adolescents, and it's actually the third one down. So that's the DTaP, which you use in those under 7 years of age. And the recommended schedule, how the CDC says you should do it, is the first dose at 2 months, the second dose at 4 months, the third dose at 6 months, and then the fourth dose should be at 15 to 18 months. And then the fifth dose is at 4 to 6 years. So that's one of the things the Ohio Department of Health is emphasizing sort of out there. If you've seen some of the media campaigns, the bulletin boards, is knowing the goal for the fourth dose DTaP is between 15 and 18 months of age. So this is the 2015 National Immunization Survey looking at receipt of 4 doses of DTaP vaccine among children 19 to 35 months of age. So the goal is 90%. The U.S., it was a little over 84%, and Ohio was about 81%. So we were lower than the national average. And this is looking at the years 2014 to 2016. This is our AFIX levels in Ohio. This starts a little later as far as an age, so this is looking at 24 to 35 months of age in childhood. And that first column there is the 4 doses of DTaP. So for 2014, it was 75.4%. 2015 was 74.6%, and 2016 about 73.6%. So if you look at these vaccines overall, it's the one that's got the lowest rate for completion of the series. Some of the other ones, the goal for most of these at the national level is 90%, so you can see that we exceed that with polio, or at 90.4%. MMR were pretty close, 89.6. 3 doses of Hib is 92.8%. 3 doses of hepatitis B, 89.6%. The 1 dose varicella is 88.7%. And a little dose lower for the 4 doses of the pneumococcal conjugate vaccine at 82.8%. So it's the toxin Bordetella pertussis that causes the disease. So in making the vaccine, we put in antigens, and all pertussis vaccines contain 2 or more different antigens. So they all actually contain an inactivated pertussis toxin, which is a toxoid. And then these other components, the number of them and how many there are, varies with different vaccine formulations. So they may contain the filamentous hemagglutinin, they may contain various V-embryo proteins, and they may contain protactin. There is a new concern that some Bordetella pertussis strains are losing some of those antigens, especially the protactin, but I don't know yet that we can really say that that's a cause for the increased incidence. It may be contributing some to disease in like vaccinated individuals, but these strains that have lost protactin don't seem to be quite as virulent, so that disease tends to be a little milder. And that's why all the vaccines have multiple antigens to sort of allow that if the strain loses one of these antigens, you'll hopefully be making immune responses to the other. So this is looking at this duration of pertussis immunity after DTaP immunization using a meta-analysis. So as we've already noticed, pertussis disease burden is increasing. The highest incidence of disease is in the 0 to 2-year-old age group. Looking a little bit at Canada, Canada introduced DTaP in 1997, same sort of reason we did, fewer side effects compared to the whole cell vaccine. And their immunization schedule is kind of similar to ours. It's the 2, 4, and 6 months. There's a 12 to 23 months, so a little bit more wider range for when they give it. Again, the 4 to 6 years. They do the adolescent dose a little later than we do. We do 11 to 12. They do 14 to 16. And then there's also adult doses. So the purpose of the study was to better understand the waning immunity of pertussis vaccine and the impact on the pertussis disease burden. And so meta-analysis is using statistics to kind of contrast and combine results from previous studies that have been done in different ways in kind of the hope of identifying patterns by having a higher statistical power. So the articles that were included were primary research articles that did not include modeling studies assessing long-term immunity, which had more than 18 months of follow-up, among children who'd received from 3 to 5 doses of DTaP vaccine. They screened 389 articles, but actually only 11 met those criteria for use in the meta-analysis. And of those, 6 studies had data on 3 doses, and 5 studies had data on 5 doses. The 3-dose studies were conducted in 2001 to 2006, and the 5-dose studies were conducted 2010 to 2013. The studies all measured the yearly incidence of pertussis. One of the difficulties was that they used different diagnostic methods. So some used PCR only, some used culture or PCR, some just used clinical symptoms, and there are a few that used serology, looking for a 4-fold rise in antibodies to the pertussis toxin. So what their results were was the risk of acquiring pertussis comparing 2 to 6 years as compared to 1 year after the last pertussis vaccine. So this basically shows that your odds ratio goes up the more years you are out since your last pertussis vaccine. So at 2 to 3 years, the odds ratio is about 1.42. 3 to 4 years, it's 1.77. 4 to 5 years, it's 2.81. And then 6 years, about 5.14. So that's why we're saying somewhere in there, that 3-4 year mark, 4 to 5 year mark is when you're really losing that waning immunity from the vaccination. So this is looking at the estimated probability of vaccine failure based on different levels of efficacy. And so on the y-axis is the probability of a vaccine failure, and on the x-axis is the time in years since your last DTaP vaccine. And you can see, looking at different levels of vaccine efficacy, whether it's 80, 85, or 90%, they all pretty much follow a similar curve. And so by the time you're out there at like 7 years or so, there's a 0.8% probability of vaccine failure. So the conclusions were the odds of pertussis increased by about 1.33 times for every additional year since the last dose of DTaP. The incidence is highest in the first year, and there it's a lot that even though they start their vaccination at 2 months, 2, 4, 6, it takes them some time really to get that primary series completed and have some immunity. The second highest incidence was the 10 to 14-year-olds. The average duration of protection after the 5th dose is only about 3 to 4 years. So there is some concern that the booster dose, if you wait till 11 to 12 years, could be a little too late. Whether you really wouldn't need, if you're getting that 4th dose or 5th dose rather, at 4 years, do you really need something in between there, like something at 7 years or something? And then the current recommendation in the United States, unless you're pregnant, is you just get the 1 dose of TDAP, and then your subsequent 10-year boosters are just the TD without the pertussis component. But whether we really need to move to vaccinating adults more with Tdap as well. So I think you can see the effectiveness of the currently licensed pertussis vaccines, both the one we use for children, the DTaP, and also our adolescent Tdap vaccines, is probably only about 70% during the first year after vaccination, whereas for tetanus, the efficacy is closer to 100%. And so the problem is this protection wanes quickly, with the effectiveness decreasing to about 9% by 4 years after vaccination. So remember that just because you're, quote, up to date on your pertussis vaccines, you can still get pertussis disease, but the benefit from being vaccinated is that disease is usually milder. And so researchers are working on new pertussis vaccines, but at least for right now, there's nothing really close in clinical trials to be licensed to replace. So I think right now we really just have to work with what we've currently got available for pertussis vaccines. So with looking at the infant and sort of safety monitoring with the vaccine adverse event reporting system, we haven't really found any significant health concerns related to the vaccines, and there's been no increased risk of adverse events. So next, we're looking at pertussis sort of treatment, prevention, outbreak control. So the most important thing with preventing pertussis disease, as it is for most of the other vaccine-preventable diseases, is to get vaccinated. So with the antibiotic treatment for pertussis, it's probably not really that effective for the individual patient after the cough is already established. What it does do, though, is it decreases that shedding and decreased risk of transmission to others. And so that's why we do recommend treating pertussis whenever it's diagnosed in that case patient. Most of the time you're going to use the macrolide antibiotics, and probably the one that's used most often is azithromycin because it's the shortest course of 5 days. Clarithromycin is 7 days, and erythromycin is 14 days. And especially with erythromycin in young infants, there is a concern that it might precipitate pyloric stenosis. If for some reason they're allergic, can't take the macrolide antibiotics, the alternative is a 14-day course of trimethoprim sulfamethoxazole. So these are some of the other things we do if you have pertussis. If you actually happen to be hospitalized, we're going to manage you in respiratory or droplet precautions. As I mentioned earlier, antimicrobial therapy of patients. For like household members, close contacts, there's post-exposure antibiotic chemoprophylaxis. And then also if you've been exposed to pertussis, it's the time to get your immunizations brought up to date if you're inadequately immunized. So, as I mentioned, if you're not unimmunized or underimmunized and you've been exposed, you should be brought up to date. You use the acellular pertussis vaccine, the DTaP, for people 10 years of age and older. And it's also probably okay to use it for 7 to 10-year-olds if they're underimmunized. And as we've discussed earlier, pregnancy is not a contraindication for DTaP. It's recommended during each pregnancy at 27 to 36 weeks gestation. So the chemoprophylaxis we give to household contacts, even if they're asymptomatic, and particular attention if there's an infant less than a year of age. Some of the others, if they've been somewhere that they've had a lot of face-to-face exposure within 3 feet, if they've been in a closely shared confined space for more than an hour, like sitting next to someone on an airplane. And here you should start the chemoprophylaxis antibiotics within 21 days of the exposure, so you've got some time to get them started. So some of the key points then, pertussis is most common in those that are least well immunized, so those under 6 months of age, and also in adolescence as that immunity sort of wanes. Reported pertussis is only a fraction of the actual disease burden. The diagnosis is often delayed in adolescents and adults, and adolescent and adult pertussis can also be severe. Infant pertussis is what's really the most severe, with a lot of morbidity and mortality. The diagnostic test you choose depends upon how long the patient's been ill. Probably most of the time what you're going to have the most readily available is going to be the PCR. The antibiotics decrease transmission, but they may not really shorten the course of illness for an individual patient. And immunization is recommended for women during pregnancy, irrespective of their prior history of receiving DTaP. Okay, so next is with vaccination barriers. And we're going to focus on this 4th dose of DTaP, but actually a lot of these factors really apply to other vaccines as well. So these are just some of the factors that can affect timely administration of vaccines. So there's various personal and family factors, what sort of health education is provided to parents and families, physician education, or also that could be healthcare provider education. And then, coming in for an immunization well-care visit, there is going to be some time and cost associated. So with the personal and the family factors, I think they sort of have to weigh the risk of disease versus the risk of vaccination and kind of their preference for one type of risk over another. So with some diseases like meningitis, I think that still evokes a pretty profound sense of fear in families. Pertussis may not be so fearful. I think those photos are kind of, they think of a young child, there's a lot of cough, there's an antibiotic for it. I think that they kind of think of the child that sort of stays in the ambulatory setting, gets treated, and eventually gets well. So I don't think they really think necessarily of the 2-month-old who's in the hospital in the ICU, pneumonia. So that could be something that I think you could use to educate families, especially those with young infants who may be hesitant about giving like the 2, 4, 6-month doses. Trust, I think, is a key component of information exchange at every sort of level. I think the other thing to emphasize, there's a lot of concerns about safety. And yes, all vaccines do have some side effects, but I think you have to put put that in relationship with that overall, the DTaP vaccine is very safe, and it's much safer to get the vaccine than to get pertussis disease. For some families, you've got to really get them into the healthcare system, so really providing that mechanism, because if they never come in contact with the healthcare system, they're never going to get their children vaccinated. So the strongest compliance seems to be for children that actually have some place that they actually call their medical home. It's where they go to get their health care. They get their well-child visits. They see them when they're ill. They give them the vaccines. But the public health clinics also serve as an important safety net for many children as well, especially to get vaccines. So some of the other personal and family factors, the access to immunization is influenced by the nature of the healthcare facility and the services available. So some of these clinics may just have a lot of walk-in acute care cases that they're really busy with, and so they may be a little less likely to pay attention to immunizations than a pediatrician or a family practice physician with whom the parent or family has a more established relationship. With health education provided to parents and families with giving them vaccine information, it needs to be presented in a form that's easily understood by the lay public, so something that's very clear, concise, credible. We give them the vaccine information, statements by the CDC. It's a requirement, but I think sometimes that just kind of gets glanced at a little bit. So I think sometimes you can help at least make sure that they got some of the 5 or 6 maybe key points off that sheet, so they really are making a good decision. You can educate them about the disease and its risk, about the safety and effectiveness of the vaccine, what are really the true contraindications and precautions. So educating them that just because the child has a cold doesn't mean they necessarily have to delay the vaccines, and really what the steps are that are required for successful completion of the whole vaccine series, that it's not just a dose at this visit, but there's going to be follow-up visits to get the whole series, and really getting the whole series gives you the best protection. So these are just some of the different sources of health information that's provided to parents and families. So health professionals, most of them would say is their most trusted source, but they also get a lot from families and friends, other people in the community. Mass media campaigns can be highly effective, and that's what the Ohio Department of Health is working on now. If you've seen some of those billboard ads with the importance of the 4th dose of the DTaP. Polio advertising using mass media, they got in excess of 99% of target groups during the polio eradication initiative during the 1990s. Now, polio may have been a much more sort of frightening disease with the whole idea of paralysis. So I think we're going to have to see how these public service announcements actually work out with the DTaP 4th dose. So you can do radio, you can do TV, and various print media. So physician education, really knowing the immunization schedule, including the footnotes, knowing the timing recommended by the CDC for the 4th dose DTaP is 15 to 18 months, which I think on the pretest survey it was about 77% answered correctly. So there's some education that needs to be done there. Really knowing what valid contraindications and precautions are, reasons to delay the receipt of specific vaccines, really having access to an accurate immunization record for a particular patient. So just asking parents, they often say the child's up to date or the child gets vaccines at multiple sites, but then really assembling all those multiple little pieces to really come up with an accurate immunization record for that particular child. Most offices now have some sort of an electronic health record. There's also state immunization registries, but then being able to use these efficiently to really get that information and really being able to inform immunization needs for patients. A lot of those electronic health records, knowing the one we work with here at Cincinnati Children's, it's very good at actually putting things in and helping you with billing and things, but then asking to tell me how many clinic patients are 14 months of age and going to be due for a fourth dose DTaP next month may be a harder task to try to do. And then tracking immunization status for patients actually takes time, and it also takes some staff allocation as well. And most offices are already probably busy with all the things you have to do with well-child visits and tracking families for other following up labs and other tests and things as well. So with any sort of visit, there's going to be some time and cost associated, so how well they can schedule that visit. Are you coupling immunizations with well-care visits, or do you have immunization-only visits? Because there is going to be some time away from work, daycare, or school. What hours? Are there evening hours or weekend hours potentially available? And then with cost, whether they have private or public insurance, there is, though, the Vaccines for Children program. So cost probably really shouldn't turn out to be a major barrier for most children to get the routine childhood vaccines. So this was a survey done in Texas regarding that fourth dose of DTaP. So it was the Texas Immunization Stakeholder Working Group Survey of Barriers to the DTaP fourth dose. And this was kind of what they ranked as what was most important then as a barrier. So kind of thinking there was a lot of misunderstanding or misinterpretation of the vaccine schedule, providers being confused about when to give it, the record keeping with the parents, so really having that accurate immunization record. For some children, they were lost to Medicaid. Many children didn't have a medical home, and there were a lot of vaccines and a lot of visits to try to complete during those first 2 years of life. So those seem to be, to them, the major sort of barrier. So this is the Ohio Provider Survey results. So the objectives of the survey then, what ODH really, Ohio Department of Health really wanted us to try to determine is what are the barriers to childhood vaccination, especially that fourth dose of DTaP. So to try to identify practices that are used by Ohio providers to increase immunization rates and what some of the key implementation challenges were. And then for those of you who took the pre-test, to test providers' knowledge about pertussis, immunization rates, and intervention practices. So this was a survey that we designed using the REX group as a consultant. It was designed and administered using Qualtrics, a company out of Provo, Utah, which is a web-based survey platform. The target population was Ohio physicians who work in a clinical setting that provides immunization to children. So the survey was sent to all physician members of the Ohio chapter of the American Academy of Pediatrics with deliverable email addresses. So that's about 2016, and it was sent out between May 9th and May 29th, so over a 3-week period, about once per week, and then there was a final kind of survey reminder just as the survey was closing. Responses received from 146 of the 2016 invitations sent, so only about 7%. 130 of those met the inclusion criteria of spending any time working in the clinical setting that provides immunizations to children. What we realized kind of afterwards was one of the limitations was really defining the number of invitations that were sent to physicians who met that inclusion criteria. So a lot of invitations probably went to people like me who were at academic medical centers, who were subspecialist providers, and weren't really at a primary medical location to fill out the survey. So we tried to go back and figure out how many people we thought were really members of the Ohio AAP and probably were primary care providers, and we thought that might come down to only maybe 600 or 700 or so. And then the other thing we had to think about was a lot of people are in group practices, and whether one person sort of went in and did the survey for the group rather than having, 4 or 5 people in the group really answering that survey because it was sort of more the asking about the practice. So I think the one caveat is how well we can generalize from the survey to other Ohio providers has to be considered, but we can at least look at what that group of providers did have to say about this. So this is the demographic results. So of 127 with the work practice, about 39% were in private practice, 26% were in the health department. And then the location of the work setting, about 37% was suburban, 22% urban, and 21% rural, with 20% being in the intercity. And then the number of pediatricians actually in the practice, the mean was 5.4, and the median was about 4. So 73% of practices did offer a 15-month well visit of the 127. So that was, I guess, sort of giving with this 4th dose of DTaP, you had a potential opportunity then to give it at the 15-month well care visit or at the 18-month well care visit. And so they estimated their percentage of their annual visits that were well care for children 15 to 18 months of age. Mean was about 14.1%, median about 7.5%. We asked them about the third-party payer mix, and about 51% was Medicaid, 35% was commercial insurance, and then the rest there was either no insurance or self-pay. So their estimated rate of children receiving the 4th dose of DTaP by 24 months, the mean was about 76.9%. So that was pretty close to what we saw with the AFEX. The median was about 80%, and the quartile range, what they estimated, was 70 to 90%. So next we asked them to indicate the extent to which each of the following parental factors was a barrier to children at their practice receiving all the recommended immunizations. So these next several slides all use the same sort of color scheme. So the very darkest blue is something they felt was a major barrier. And then there's kind of a medium blue that's a moderate barrier. And then the slightly lighter is the minor barrier. And then the sort of really pale blue is not a barrier at all. So what they felt were kind of the biggest major barriers were the parent forgetting to make or canceling the appointment, or the parent's inability to keep the appointment. Some of the other ones, as you go on down, belief that vaccines cause health problems was a moderate barrier for 34% and a minor barrier for 54%. The belief that vaccines are ineffective or unnecessary, again, 57% felt that was a minor barrier. Some of the other ones, as you go down, the desire to spare the child from pain and discomfort, refusal due to religious or philosophical reasons, misunderstanding of the immunization schedule, some problems communicating due to language barriers, and perception that there were extra out-of-pocket expenses, but they felt 60% that the cost really wasn't a barrier at all. Next, it's sort of the same question, but it's a barrier now for that 4th DTaP dose and the child receiving that 4th dose by 24 months of age. So again, they had the same things at the top, either the parent canceling the appointment or not showing up for the appointment, or forgetting to make the needed appointment. Other things as you go on down, unaware that a 4th DTaP dose was needed. That was a moderate barrier for about 20%, a minor barrier for about 36%. Again, the belief that it wasn't necessary was a moderate barrier for 33%. And the perception that the visit will cost extra was not a barrier for 75%. So with these, we're getting sort of one side of the story. This is what we as healthcare providers view as parents. Unfortunately, we don't really have whether the parent really feels like that these are the big barriers for them. And then this is more about practice factors, so indicating the extent to which each of the following factors related to your practice is a barrier to children receiving all recommended immunizations. So again, it's the same sort of color scheme, the lack of options for just-in-time parent reminders, so being able to provide a reminder. That was a major barrier for about 9%, moderate barrier for 27%, and a minor barrier for 34%. So overall, some sort of barrier for about 70% or so almost. The lack of the technical ability to use their electronic medical record system to do recall was overall some sort of barrier for about 60% or so. Other priorities, leaving not enough time for immunizations, was at least a minor to a moderate barrier for about 40-some%. Staff limitations overall amounted to some sort of barrier for only about less than 30%. Inconsistency in stressing the importance of immunizations, again, about 30% or so, some sort of barrier. Lack of information to give to parents about children's immunization status was really just viewed as sort of a minor barrier. Confusing vaccination schedule, only again more sort of a moderate to minor barrier. Lack of process for administering outside of well visits, again more of a minor factor. And again, the financial incentive being at the bottom, with most of the time not be a barrier at all. And we didn't really show this for the fourth dose of DTaP, but it's overall pretty similar as well. That really the difficulty with doing good reminder and recalls was one of the problems that was identified the most. So what interventions has their practice implemented to try to improve immunization rates? So 61% do provide parent education materials to try to increase awareness. 42% have implemented some sort of timely well visit, reminder, recall sort of process, flagging charts to identify patients who are overdue for specific immunizations. And then 30% have added either immunization-only visits or changed their workflow to try to promote immunizations at more acute care or ill visits. So overall, a lot of them are doing something. Some of them may be doing more than one of these practices. And then for each intervention that they implemented, asking them what they saw as sort of key barriers or challenges. So with trying to give parents educational materials to increase awareness, they felt a lot of times that parents didn't read them or weren't really paying attention and learning the information, often leaving the room. Sometimes the provider forgetting to provide the information. So sometimes it may just be with giving that vaccine information statement, just sitting down and at least, telling them maybe the three most important points on that vaccination sheet. With trying to implement systems to encourage timely, well-told visits, really the big one was lack of time or lack of staff, and then again the parent problems with either canceling or not showing up for the appointment. With trying to do the recall, again, lack of time and staff. Sometimes it was hard with address changes, some of the cell phone numbers no longer being active, so really trying to keep good contact information for the family to try to recall them once the child's behind on an immunization. With reminders, so the reminders are trying to tell them ahead of time that a vaccine is going to be due. Again, lack of time and staff, and again, that problem with being able to reach the families. Some of them use chart flags to try to identify patients. A lot of these electronic medical record systems have a lot of flags you can put in, so they sometimes felt like there was a lot of flag overload, and if you're in a hurry, you just kind of ignore the flags and go on. Sometimes the electronic health system seemed to be a little too rigid with trying to use it to put flags in that you want and get rid of other flags that you really don't use very much. With trying to add a 15-month well visit, there was difficulty with scheduling, with parents being busy, or again, the parents canceling and not showing up. Adding immunization-only visits, you have to have then a nurse provider being available to give that vaccine. Again, the parent may still not make or keep the appointment. And then with trying to change workflow to promote immunizations at ill visits, again, it's going to take time and staff. And I think there's still a lot of reluctance, even though you try to say the child only has a minor illness, like a cold, and it's okay to immunize. I think there's a lot of perceptions that vaccines make children feel more ill, and they don't want to do it if the child is not completely well. So we're going to look now at some strategies to try to increase vaccinations. So this you're probably familiar with. These are kind of the same things that we talk about with our MOBI and TIES presentations. And so what's really the top of the list is trying to use an immunization reminder or recall system for every patient. Other practices you can do is having someone in the office who's really sort of a go-to person for vaccine questions. It doesn't necessarily have to be the physician. It can be a medical assistant who's sort of, paying attention, looking as the child's coming in. Are they up to date on their vaccines? Giving all vaccines that are due, regardless of the number of injections. Again, that may take some time to sort of tell the parent that it's okay that the child's going to get 4 IM shots at that particular visit. Allowing shots to be given to children with minor illnesses like just colds or low-grade fever. Next is having patients come in for immunization-only nurse visits. I know a lot of practices do that with the flu vaccine in the fall, or potentially, especially like summer, like the week before school starts, and there's a lot that are trying to come in. I'm not sure how often they do it all during the year, if they have opportunities all during the year for that. Giving age-appropriate vaccines when no vaccine record is available, using combination vaccines, and then really making sure that if you're not giving a vaccine that there is a valid contraindication or precaution. Some of the best practices for office operations, including having a free AFIX, or assessment, feedback, incentive exchange measurement of your vaccination rates every 1 to 2 years, so really knowing what your rate is and how you compare to the rest of Ohio, how you compare nationally. Are you a Vaccines for Children provider? Do you give them a current vaccine information statement to the parents prior to every immunization and every visit? You can allow it to take them home. I've seen other practices that will just sort of laminate it and have it there, and then the family leaves it at the office. I'm not sure they probably do that much with it necessarily if they take it home. Some may not. Making sure there's a written plan for protecting vaccines if you do have a power outage. Using the Ohio Immunization Registry, the Impact SIST, which there's supposed to, I think, be some updates with that to making a better system to enter the immunization information. Checking the vaccine status at every office visit, which it sounds like many of our respondents are doing, and having resource materials available to address vaccine concerns. So reminder and recall is the single most effective way to improve immunization rates in a practice. So with immunization, reminder, recall, reminder are basically the vaccine is going to be coming up and due soon. And then recall is for children who are already behind or past due for 1 or more vaccines. So the reasons to do reminder, recall, the most important one there is to raise your immunization rates. You also heighten awareness of the staff for kind of that continual need to check the immunization status of their patients. And it also provides a service to parents to help them keep their children on time with healthcare visits, because often the immunization visit is combined with a well child care visit. So remember that your recommendation as a healthcare provider is what parents view as the most powerful motivator for complying with vaccine recommendations. And you can reinforce what you say with that need to return on time using what you say, but also you can use written methods. Actually having a calendar can help as well. So this is the 10 steps of immunization reminder and recall. We've got the website there, the American Immunization Registry Association. So this is probably more than you ever wanted to know about immunization reminder recall. The whole document is probably over 100 pages. But I'm just going to sort of hit some of the high points here. But it is a resource if you want more specific details about how to do a specific piece in your office. So first is you've got to formulate your reminder and recall criteria. And you may just want to start with something really simple at first, very well defined. So if you're going to look, for example, at that 4th dose of DTaP, maybe I want to identify all of those who are behind. So say those who, for example, are already like 18 to 24 months and behind then. And then you've got to decide who's going to be responsible actually for going through your electronic medical record system, trying to actually figure out how these children are, and then defining other sort of reminder and recall sort of considerations. There may be some other additional conditions that you have to sort of define. It may be a child, as you're going through, you're realizing that it's a parent who's going to refuse vaccines. They haven't, been vaccinated for many months or whatever. There may be patients in there that are no longer in your practice and are going somewhere else. There may be children who are getting their immunizations at the health department. So you've got to sort of get those sort of down to really the ones that you really are responsible for as the provider then who are really sort of behind. So that's kind of that generating and revising that list of potential patients. So now that you've got that list of potential patients, you've got to sort of figure out how you're going to tell them now that, in this case, the recall, that their child is behind for this particular vaccine dose. So there's various different ways to do this, and I think some of this is kind of knowing the family, knowing what's going to work for your practice, knowing how much staff time you've got to devote to this. Many of the studies show that if you can make a person-to-person phone call and actually get the parent on the line, and it's someone like in your front office staff who they recognize and see the importance of it, that at that phone call you can actually hopefully get that visit scheduled as well. Some will use more sort of auto dialer phone systems, a little less personal. If you know the family and kind of have things set up, you may be able to do text messages. A lot of practices will do a postcard, so they may be there for like the 3rd dose, and then while they're there, you'll actually have a postcard that's already stamped and has the information on it, and so all the family has to do is write in their correct address, and then when the child then gets ready for the next immunization visit, you can send that postcard out a few weeks ahead of time, or it may have like an alternative message on there that if they get behind, that they're actually late for that visit. Letters are another way you can send out. Many of the electronic record systems actually, and also Impact Cyst, Ohio Immunization Registry, do have these patient portal alerts that can actually send an alert to the family, letting them know that a visit is coming up and needs to be scheduled. And often those systems do have online ways of scheduling the appointment at the same time. So this was it was a study done in Colorado, and Colorado State Immunization Registry actually is very thorough. They have almost all the children who get vaccines in Colorado in that system. So they were looking at trying to do this using their state immunization registry versus just using practice-based approaches. So with trying to achieve up-to-date status, it was actually better for using the state immunization registry, 19.2% versus 9.8% for practice-based approaches. And the cost to achieve up-to-date status was actually cheaper with using their state immunization registry. It was $24.72 versus trying to do it on your own as an individual practitioner. It was over $124. But this may vary a little bit depending upon how thorough and comprehensive a state immunization registry is. So, you do some sort of notification method, and that may work for some families, but it may not work for all families. There may be one that you realize you don't have the correct telephone number for, so maybe you do have to do a letter. Most of the time they recommend at least trying to make 3 attempts to reach a family before you give up, and some offices will actually go as far as to send some sort of certified letter. So again, that's sort of collecting the responses, updating the status. Are they making the appointment, but then they're not showing up for the appointment? You may have to sort of assess that. If they do come in and get the vaccine, then you want to update your electronic record system and also the state immunization registry. And then as different practices do this, maybe even sort of comparing and sharing your results with others. And then, if you get this to work for one vaccine, then you may in the future pick a different vaccine to get it to work for. So some of the barriers here with reminder recall, again, whatever you do, it is going to take some staff time to do these sort of reminder recall. There's going to be some financial resources needed. A lot is the whole electronic medical record system and how technically capable it is to actually run the report, use the data from the electronic systems. Some of these systems, there's, especially for the child who's getting vaccines at multiple sites, there may be sort of not very much confidence in the accuracy of the patient immunization record, that there's not a lot of good data sharing among multiple immunization providers. To do this may require changes to staff workflow, and oftentimes I think when you do something, if you don't see the success with it, you may tend to give up on it or not really feel that this is a good use of time. So I think if you can sort of do it and then, look at your AFEX, look at how many were coming in, then that may in the short term give you more of a sense of success and more of a motivation to get the staff to continue doing things. So this is a little bit more specifically what we're talking about. This is a DTaP quality improvement project. This was done at the health department in Kansas. They used the PDSA, Plan, Do, Study, Act cycles. So they kind of created this new office flow to remind staff and parent of the appointment. So this was a lot of sticky notes and postcards to kind of remind the parent of the appointment, because a lot of their problem apparently was just getting the parent there to the appointment. Apparently once they got the parent there, most of them were getting the child vaccinated. So even just doing something simple like that, their 4th DTaP dose rates did increase from 70% to 82%. Again, this may have to be specific as to what the real sort of barrier is in your particular practice. Ohio's immunization registry is ImpactSyst. It can create reports for practices to help you with reminder and recall notices. So it can generate lists of children who are due for immunizations, children who have missed an appointment, and you can generate patient-specific reports on your recall attempts. If you've had an AFEX, you can look at your AFEX rates, and especially if you have multiple ones, you can look and see if you're improving over time. So kind of using data from AFEX or other surveys to determine the best time to do your recall notices. So it looks like overall in Ohio, this 4th dose of DTaP is the one that has the lowest on-time rate for 2-year-old children. So especially if they get beyond 18 months, you want to recall them to make sure you're getting them in. and then using the data to see when children are missing their vaccinations and then target that age to improve rates and outcomes. These are just some AAP resources that they have to help you with doing reminder and recall system as well. And both of those have a lot of good resources for making reminder and recall systems work. So the last part is we have some tools. So we have an immunization provider letter about the importance of timely childhood immunizations, especially the 4th dose DTaP. We have an easy-to-read 2017 recommended immunization schedule for children from birth through 6 years old. So it's got the schedule on the one side, and then if you flip it over, it's got some information about the diseases. So that's something you can actually give to a parent. It's more sort of pictures. It's more sort of parent-friendly. And I think, if you're doing that and pointing out where they are along there and then when the next visit is due for a vaccine, that can actually be helpful as sort of a calendar-based method. And on the other side, it actually has a little bit more about pertussis and some of the more serious complications of pertussis. There's actually a specific information sheet about the 3 diseases that this vaccine protects against, so whooping cough, tetanus, and diphtheria. I often think tetanus isn't out there, but I can tell you in the past year I have taken care of a little Ohio boy who actually had tetanus because he wasn't immunized, and it was just a very simple little injury. He scraped his knee outside on the farm. So I don't think that tetanus doesn't happen, because it does. Diphtheria you probably won't see in the United States, but it is still out there in the rest of the world, and the vaccines actually combined. You've got all 3 in the one vaccine. We've got some things about best practices for increasing vaccine rates, some actual reminder and recall scripts that you can use for phone calls, voicemails, text messages, and emails. We have the parental refusal pamphlets, which we'll talk a little bit more on an upcoming slide. And there's actually a DTaP reminder postcard. It's already posted. It's already got the message and everything on there, so all it has to do is be addressed. And you can actually have the parent address it at one visit in preparation for an upcoming visit. So these are just these parental refusal brochures. These are available from the Ohio American Academy of Pediatrics. We have them kind of color-coded with the red, yellow, and green. So green is kind of the go. Your child thanks you. They vaccinated their child. The yellow is kind of the caution. They're a little bit hesitant to give the vaccine, and so we're trying to encourage them why vaccination is important. And then the red is they basically stopped. They don't want vaccines. And again, we're trying to point out why they should vaccinate their child and also dispel some of the myths. So you'll notice there, vaccines do not cause autism is one of the major messages. We also have a mobile app. This is the Fax mobile app. You can search for it free in the Apple App Store or in Google Play. So if you look there, the first is actually you can choose whether you're a parent or family member or whether you're a healthcare provider. For the healthcare providers, we have information on immunization safety concerns that you can share with parents on a tablet in your office. So you've got facts and resources directly from the app screen, and there's also various conversation tactics to try to use to combat vaccine refusal. For parents, there's actually short videos that have been recorded by pediatricians on targeted topics that address the common immunization concerns and questions. There's an interactive immunization schedule that they can customize to their child's age. There's breaking news alerts about immunizations, and there's pediatrician-approved links and resources. So if they use those links, They're going to be ones like the CDC, the American Academy of Pediatrics. They're not going to be from like the anti-vaccine groups that if you just kind of go online and type in immunization, where you may end up is in an anti-vaccine group web link.
Okay. Well, thank you very much, Dr. Brady, for this presentation.
Thank you for participating this evening.